Good afternoon. I would like to welcome you all today to today's webinar. A few things to note: participants will be muted upon entry and videos turned off. For technical assistance, please use the chat box. You will receive an email in approximately 3 months requesting feedback and impact on this presentation. We ask that you also check your junk or spam folders for this email if you have not received it. And lastly, we'd like for you to visit www.ncdas.org/training to view other training opportunities that we may have. Immediately following this webinar, you will receive handouts and an evaluation. Once again, please check your junk or spam folders for this email if it is not received. I will now begin to introduce today's speaker. Our speaker today is Dr. Rachel Good. She is an assistant professor at the School of Social Work, University of North Carolina at Chapel Hill, and a key content expert with the National Center of Excellence for Eating Disorders. The focus of her research is to develop, implement, and evaluate interventions to prevent and treat disordered eating and obesity among African American women. Her ongoing projects include a Feeding Hope grant from the National Eating Disorders Association to prevent binge eating disorder among African American women in primary care. I will now welcome and turn things over to Dr. Rachel Good.
Thank you, Lachelle. I am excited to be here with you all today. I look forward to our conversation. I know that we are going to learn from each other. I look forward to sharing what we know now about eating disorders in Black Americans and what we still need to know, just to encourage some of you all. I know some of your researchers out there, students, other clinicians, as we continue to make our evidence base stronger for treating eating disorders in all populations. So just at first, I'm going to go over just kind of what to expect from today. So I'm going to describe the prevalence of DSM-5 eating disorders and just some of the challenges in access and treatment retention for Black Americans. Also, we're going to discuss the relevant factors in the development of eating disorders in this group, and then some strategies for culturally relevant assessment and treatment of disordered eating behaviors. So just to set our conversation, I love sharing this slide because what many of us know is that there are a lot of misconceptions about eating disorders. We have a lot of different ideas, but I think two that are going to be most relevant to our conversation today is first that eating disorders can affect anyone. I know we may have ideas about who eating disorders affect and who they don't impact. Historically, the stereotypes abound. And so we're going to unpack some of that today. But we need to move forward with our research, with our practice, with our work, understanding that eating disorders affect anyone and that you cannot tell if someone has an eating disorder just by looking at them. Again, this stereotypes that we have believed has really hindered us in our ability to help more people. So hopefully moving forward, we're going to make some changes. So I use these images to talk about who struggles with eating disorders, because I think these are some of our stereotypical beliefs about just who is most impacted, what the achievement of the thin ideal, mostly predominantly white, adolescent, young adult women. These are kind of our stereotypical images. But of course, what we all know and what we're coming to learn is that all of us are equally as likely to be able to struggle with an eating disorder. And so our work is to really begin to understand why, right? Some of the reasons for eating disorder development are different in populations, right? And so today I'm going to help us understand what's the why in Black American populations so that we can be a little stronger and better in our help. So just to kind of get beyond some stereotypes, binge eating disorder is actually the most common eating disorder across racial and ethnic groups and in Black Americans. And so moreover, rates of binge eating may be similar or even higher in Black Americans as compared to whites. And then we are learning over the last couple of years, we've seen emerging evidence on the role of poverty and food insecurity and how that might increase rates of binge eating. When we think of just the prevalence overall of eating disorders in Black Americans, anorexia nervosa is the least common eating disorder. And then bulimia nervosa and binge eating disorder are the most common. And so here there is data from 3 epidemiological studies that have examined eating disorder in samples of Black Americans. And so some of our earlier studies were reporting, the DSM-4 estimates. And at that time, binge eating disorder wasn't formally recognized. And so you see, some of the differences for the lifetime prevalence. But this just to know that currently with the DSM-5 diagnosis, that binge eating disorder and bulimia nervosa are the 2 most common eating disorders in Black Americans. And so when you look at these numbers, your first thought might be, well, these don't seem like it's that common. But as we'll see further in this presentation, there are many, many individuals who do not actually get treatment for eating disorders across racial and ethnic groups. And so with these disparities, there are likely more eating disorders in our communities, in our clinics that we don't even recognize. And people are going largely diagnosed and unhelped. So I think it's important to set the stage on just some of the cultural factors that really influence the relationship to food and the relationship to disordered eating in the Black American community. And so one of the first is historically, when we think about eating disorders, the over-evaluation of shape or weight has, historically been connected to an increase in disordered eating behavior. And so we've thought that Black Americans have been protected from that because what we see is that there is less emphasis on achieving the thin ideal that we commonly see in white American population. And so what we also know, though, is that if we think about it and when we really understand, there's a crease, we might be able to say more accurately, there's more flexibility, right? Black Americans also have their idealized body type. It's different from the white majority, but there are still idealized body types that still kind of, that struggle to, embody that look still plagues many members of the community. In addition, because of the stereotypes, there's just a lack of eating disorder awareness. And so if you are a clinician and you recognize an eating disorder in this population, one of your first stops needs to be psychoeducation, because often people, I think, because of the misinformation, people don't think that they're susceptible. And so they can hide in plain sight very, very easily within this community because people just really don't understand, some of the risk factors and some of the symptoms to be able to diagnose them. In addition, I think we also really need to understand the meaning of food to African American culture. When we look at the historical legacy of African Americans in slavery and how they were given often the scraps, the things that were left over to have to make meals with, to make mosaics of beauty in oppressive conditions at best, there was extreme poverty. And so families were having to kind of create, and many of the women were responsible for creating these just these bountiful meals with things that, often maybe did not have a lot of nutritional value, but would go further in their family. And it was an act of love. And so there is, to this day, there is a large amount of, when you think about food and celebrations, food has such a central purpose in African American families and homes. And it just is something that if we're going to understand how disordered eating might manifest and the role it might have in this community, we have to first be able to really think about what it means and how important it is to just how people show love within the community. And so as you all look at this list, these are some in the literature, what we know now about some of the common factors that contribute to eating disorders in this population. And so I'm going to go through and talk about several of these in a little bit more detail. So the first is poverty and food insecurity. And again, this is an emerging area, but mostly in the US, about 88% of our homes would be considered food secure. However, that 11% of individuals who are managing, and not really always knowing where their food will come from, you see here that there is just, there's some disparities. And so when we look at the literature in individuals who come from homes where there is low food security or very low food security, and we consider very low food security homes where there's children that we may not know whether or not they're going to have access to a meal. And so those homes where there is the lowest amount of food security, we see increased binge eating behaviors, increased binge eating pathology. We also see that in individuals who are Supplemental Nutrition Assistance Program recipients, so the SNAP program, and that program traditionally gives benefits one time per month. And so again, in some emerging research, we see that individuals who are part of that program tend to have higher rates of binge eating. We've wondered that if it's that relationship between, there's a period of time where the benefits run out. And so individuals have about a week, families have sometimes a week, 7 to 10 days where they are trying to make things stretch. And so we see individuals getting in patterns where there's restriction, and then when food is restored, it might increase the likelihood of binge eating, similar to what we've seen when individuals may diet. It was just an area that we see also affects Black American families, because currently households that are single and single-headed households where they're Black American women who are heading the household, they tend to have the highest rates of food insecurity based on what we know in the research currently right now. In addition, we see the role of trauma. So we understand that trauma has historically been connected, especially trauma that's experienced in childhood. And individuals who have experienced physical abuse, sexual abuse, they are, though we see in the literature that there are higher rates of disordered eating behaviors. We also cannot have this conversation without talking about the role of racism and discrimination and microaggressions. Black families, Black individuals, Black men, Black women, they manage multiple oppressions daily. And so you think about, we have gender, we have racism, we have classism. And so we also have the pressure of acculturative stress, right? And recognizing that within mainstream culture, the thin ideal is a body type, right, that is associated with privilege. And so if one is trying to, maybe make it easier, right, to fit in with the dominant community, there is increased pressure to embody that thin ideal. And so depending on whether, a Black American family might be in a predominantly white environment, you might see increased stress. And so managing these realities, especially these microaggressions, right, these daily things that you may be able to tell someone about and they may not think is valid, but what happened to you. You feel it. You feel that it's happened. And so these things add up and can also increase the risk for disordered eating. In addition, the strong Black woman syndrome. And for those of you who are not familiar with this is just kind of, again, historically a way of being. Many Black American women have had to kind of manifest this outward appearance of strength in some of the most difficult circumstances, managing financial hardship, caretaking responsibilities, managing having to just kind of show that you can do it, difficulty asking for help, and difficulty, just kind of you just have to show that you can do it all. And so what we've seen in the literature is that women who tend to maybe identify with the traits of the strong Black woman syndrome have higher rates of disordered eating. Often eating has been used as a tool to kind of quell some of the silencing that often happens, things that you're not able to say, things that maybe people wouldn't believe about your experience. You just, manifest strength, but then you are unable to really get the help you need. And so sometimes women have used food kind of as the medication in that sense. And so often we can see disordered eating develop for that reason. So when we think about, I'm going to spend a little bit of time just kind of talking about eating disorder pathology and just helping to understand what is the same when we think about how eating disorders show up in Black American populations as compared to other racial and ethnic groups in the United States, and what is different. And so this chart is from a research study in about 700 adults who were participating in treatment for binge eating disorder. And so these adults were just what we see here, just to orient you to the chart, is this is the age of participants in the study, so 0 to 50. And so most participants, we see kind of the age of onset of some of this disordered eating behavior. And so overall, what we see is that in whites, there was a younger onset for binge eating, disordered eating than it was compared to Black or Hispanic participants. And so in this blue, that is the age of onset of obesity. And so you see for whites, it was a little bit younger than compared to the Black participants in the study. And then the yellow is the age of onset of dieting. So our culture, or the response when people feel like they want to lose excess weight, they often, the first stop is a diet, right? And so, however, the next is when individuals might have felt the restriction, right? And then that might lead to binge eating. So we see this green, this binge eating. And so when you compare what we see in the Black participants versus the white participants, there is a much shorter duration of binge eating before it leads to binge eating disorder, which is severe, includes severe binge eating, and is associated with numerous comorbid conditions. And so you see there's a shorter period here. And so based on the results of this study, what the researchers noted is that the age of onset for some of this disorder is a little bit later, for Black participants. But what they also saw is that they had similar weight, shape, and eating concerns. And there are similar or more frequent binge eating episodes. And so I feel like this research really helps us when you think about what I shared in the first slide about how eating disorders, there's not, they don't look the same. You can't physically tell. And so many people, their eating disorders have gone unrecognized, including in Black Americans, because they were in maybe larger bodies, so that individuals didn't really understand that eating disorders do not discriminate when it comes to body size. And so this research just helps us see. So yes, Black Americans might struggle with some of the same concerns, right? Some of the same weight, shape, or eating concerns, but it's showing up differently. And so we're going to have to be better to receive and be able to help this population. So now I'm going to talk a little bit about COVID-19, right? We are still experiencing this, but as we are coming out and we think about what the trauma of COVID-19 was, first on individuals with eating disorders and then on Black Americans, and how that might have affected kind of their experience with managing their eating during this time, so we can understand what uniquely was going on in this period. So if you all remember, Black Americans had, disproportionate rates of COVID-19 diagnosis, mortality. And we also recognize that there was a dual pandemic of racism also going on during this time. And so with this information, you can imagine, based on some of the information I shared before, how that might have affected eating disorders. So this study was done in a group of across the United States. About 500 individuals participated, and then 500 individuals in the Netherlands. And so what we see is that eating disorder behavior was significantly impacted, right? Individuals talked about how there was more frequent binge eating, right? More frequent engagement in compensatory behaviors and feeling more anxiety about not being able to exercise, or noticing that their eating disorder was, severely impacted. We also see here in this chart that individuals were at increased risk overall who were managing eating disorders because they were exposed to, more media. There was disruption to things that the structure that they were used to having, the feeling of social isolation. They noticed that these increased risk factors, their sleep was different, and then they had lower access to some of these protective things, right? The social support, the ability to engage in the things that they used to that would regulate their emotion, and then access to the in-person treatment that they were used to. And so this combined, right, to create increased eating disorder risk. So when we think about Black Americans, my research team wanted to understand how, Black Americans who were managing disordered eating, what their experience was like. And so this March and April, probably March, April, and May of 2020, my team was able to conduct semi-structured interviews with 20 Black American women, just to hear again about how COVID-19 has affected their eating behaviors. And I wanted to share some of the responses from the participants. This first participant says, I find myself eating ice cream and cookies 2 or 3 times a day and bedtime, which are things I never did before COVID. And before COVID, I could eat a bite of any dessert and be completely satisfied. Since COVID, I have wanted to eat the whole dessert. That's different. That's very different. And I have been this way for years when it came to dessert. 1 bite, enough, satisfied, done. But since COVID, I'm not satisfied with anything. And God, it feels like I'm never done. Another participant said that I think COVID changed things for me. Most days of the week, when I'm not controlling my eating, I'm having binge episodes, and they're mostly at night. I would say it's mostly difficult to manage at night, and I work a lot. I work really long hours sometimes. And so at night, I'm up late, I'm working, I'm on my computer. And so, okay, I'm just bored and it's late and I'm working, I'm tired. Let me go get something to eat. And so in these comments, you see representation of some of the larger themes that we noticed from the participants. It's just being in environments that were more triggering, increased time, being at home in a place where their access is different, the lack of structure, boredom, feeling like they don't have as much control over their eating behaviors, and also not having as much access to food that they would normally have. And finally, that struggle with, which I shared earlier about that coping, using food as a coping mechanism and feeling like many that, that just needing something to kind of help make things a little bit better. So now I'm going to talk a little bit about just treatment, what we know about some of the disparities in treatment. Overall, what we see is that Black Americans are less likely to receive treatment for disordered eating, and they are more likely to drop out of treatment. This is a study that was done that compared Black and white women who were managing binge eating. And so what we see, the blue is Black women, and then the teal are white women. And what we see here is that the Black and the white women participating in this study were almost equally as likely to receive treatment for a weight problem, but the white women were nearly 3 times likely to receive treatment for an eating problem. When we think about lifetime service utilization, we also see disparities here. And so these are among individuals who reported any eating disorder, but no binge eating. This is DSM-4 diagnosed binge eating, and so, or eating disorders. And we see that white participants had significantly higher rates of lifetime service utilization. And so this was a study that was done in about 29 multi-ethnic women. And so we see why, right? What are some of the reasons why these women are not seeking treatment, why people are not seeking treatment for eating disorders? And near the top, financial difficulties. How are we going to pay for this, right? And that's a very valid question, because often eating disorder treatment is done in specialty clinics, and it's not always accessible for those who may not have the resources, the insurance, fear of being labeled, shame. We see that shame and stigma also contributes to, not seeking eating disorder treatment, especially, again, if it's not normalized in your community as a problem, then it's going to make people people reticent to reach out and ask for help. And then also the concern of just not really, being aware of the problem and not being not really thinking that you're going to, just not being aware of the problem. And then finally, counselors who are not the same ethnic background. And that's important to be able to identify maybe with the person that's going to be providing you care. That may be important to some treatment seekers. Another issue that might explain some of the disparities in treatment are clinicians. And there's some struggle in being able to recognize symptoms of disordered eating. So in this study, it was a study of psychologists. They were presented with case studies that described disordered eating symptoms in white, Hispanic, and Black women. And so the clinicians were asked to identify if the woman's eating behavior was problematic. And so what we see here is that 44% were able to identify the white women's eating. And so in a similar, about 41% for the Hispanic women's eating, but only 17% were able to identify the Black women's eating as problematic. And so we wonder what might be some of the reasons why our clinicians are having challenges being able to identify disordered eating in Black American populations. One might be when we think about, again, I think there's these misconceptions when clinicians might perceive eating disorders as only anorexia nervosa, preoccupation with the thin ideal, and they might miss other important risk factors. The patient, based on what we've seen, is likely not to be underweight. And so if that is the case, then the patient, might meet BMI criteria for obesity, and clinicians may feel that sharing information about weight and discussing risk for type 2 diabetes might be more important. But hopefully coming out of today, we will recognize that, again, we have to look at some of the other signs that an eating disorder might be present. And so what investigators, particularly with binge eating, what they've noticed is that in the year before treatment for binge eating might begin, individuals might manifest rapid weight gain. And so that might be a symptom if you are a clinician and you notice that might prompt you to be able to ask, and be able to kind of probe a little deeper about what has been happening. We also see, I think clinicians may not always know how to get the information, especially if you're in a setting, maybe you're a primary care physician, you're in a setting where you don't have a lot of time you're spending with your patients. And so you may not know how to quickly get the information you need. And so this is just an example of a screener that, again, 7 questions that can be asked probably in a matter of 5 minutes to be asked to kind of identify and to be able to see if individuals were experiencing loss of control. Were they eating when they weren't hungry? Were individuals feeling guilty or disgusted? Was there any purging present? Just a few questions that can be asked by clinicians to help see, like, okay, maybe there's something here and we need to refer to a higher level of care. So now I'm going to transition to just talking about what we've learned about treatment and how we might need some things we might need to consider when we think about treatment for Black Americans in eating disorders. And so we don't know, we're a growing evidence base, because I'm optimistic that we will continue to add to it and continue to expand so we can offer, appropriate, culturally relevant treatment to all who manage eating disorders. And so right now we are kind of at the beginning. I feel like we're at the beginning of this journey. So I look forward to sharing kind of what we've learned so far. So one of the first things that is going to be helpful as a clinician is you have to think about how you begin to discover and ask the questions, especially my mental health clinicians who are here, how you begin to ask your clients about their eating behaviors and the questions. And so often, many of us, when you think, if you've been trained here in the United States, most of our training has not focused on the role of race and recognizing that we might need to have some cultural relevance when we are beginning to help people and understand what the nature of eating behavior is in a client in front of us. And so many of our training has been very colorblind, right? And so we treat everyone is the same. We ask the same questions, which often do not include anything about some of the major factors that affect disordered eating in Black American populations. When we're talking about their culture, their ethnicity, and issues of race. And so here I have some assessment questions that I took from the book Treating Eating Disorders in Black Women by Mazzella Fuller and Charlene Small. And so they talk about, in the book, they talk about the importance of asking the hard questions, the things that, especially if you do not identify as a clinician of color, you might feel awkward, right? You might feel like, oh, I just met this person. Do I really want to go there? Maybe we need a little bit more time. And so I would encourage you to shift a little bit and recognize that we are going to have to take stances that encourage and give our clients permission to bring their whole identities into the treatment setting. And so we have to ask different questions, because some of the questions we ask now do not do that, right? So look at some of these examples. What influence has your race, your religion, your gender, your class, your hair? But for Black Americans, hair, especially women, hair is a significant factor. Even when we talk about skin tone, colorism has played in shaping your body image. What has it been like for you growing up in a culture of racism? Asking the factors related to oppression that your client discusses that might have influenced them, right? The triggers to eat, to not eat, the messages, cultural messages about food that they have received. And so you think about, if we took the time to include these questions in our assessment of eating behaviors, we would create an environment that would signal to our clients that they can bring more of their identity, and we might be able to help them in a different way. In addition, if we're thinking about a comprehensive assessment, we also want to be able to, examine that history of eating patterns, and when things have changed. Examine acculturative stress and what it may be like if they're in environments where they might be the only person of color in the room, and how that has experienced their relationship to their body, their relationship to eating, with, understanding, has there been food insecurity in the last several years, currently, history of trauma, what other comorbid conditions that might you be managing right now that we know intersect with binge eating, such as type 2 diabetes, managing being in a larger body, and then also encouraging the clinician to begin that journey of self-examination, clinicians of color, clinicians who identify as white, of our own cultural biases and beliefs. We can't exist and exist in our American society without the water. It's poison and it affects all of us. And so we all have to think about what we're just absorbing being here in our culture, and how that is going to affect some biases, some implicit bias that you may not even realize is there, but it's for all of us, because we're all here in this environment, and we have to recognize and deal with that so that we can be positioned to help. This is just some additional guidance. If you identify as a clinician of color and you are going to be kind of broaching this issue with another client of color, and so you have to think about, when it comes to disordered eating behaviors, misunderstanding and bias exists between people of color. And so one of the challenges sometimes is that if you are one of these individuals, your worldview and your experiences with oppression are going to have to be separated. And so in your mind, you may have an idea of what it means to show up in a certain body. So let's say you are a Black clinician, you may have an idea of what it means to show up Black, but you have to remember that your client's experience is very, very different. And so you also have to look at your racial identity status and how acculturated you are to mainstream culture, and think about how this may influence your client and how you might be perceived by your client in the room. And then we think about your office space, the inclusivity of your office space. Are there chairs for individuals in larger bodies to sit in? What are the materials like? What are the reading materials? How are you setting an atmosphere to let people know from the door that they are welcome and you care and you want to help them? If you identify as a white clinician, it's going to be important for you too to really identify and examine your racial identity. And you're going to have to make explicit that you want to know about your client's experience with racism, sexism, gender identity concerns. And you have to explicitly invite that in the room, because people may not feel they may not, without knowing that that's something that is you want to know about, people may not always feel, they might be reticent to share that information. And also, just like, we all have our work to do, right? To uncover your personal areas of bias and implicit bias, and continuing to seek out those growth spaces where you can be honest and kind of look at yourself and understand how you're showing up in the room, how you're showing up in your practice, because these are the things that really make the difference often in clients being retained to treatment. The things that no one may ever say this, but these are the things that Black Americans and other populations of color you are absorbing in your work with your clients. You're absorbing this feeling, right? And it's affecting you. And you can tell whether someone is really leaned in and they want to know about your experiences with racism, your experiences with other microaggressions. And we want to create environments so that we can get that information, because we know it affects eating behaviors. So when we think about what we know about some of the treatments for eating disorders, these are the most common evidence-based treatments that we know, particularly for when we think about binge eating. There's cognitive behavioral therapy, interpersonal therapy, and CBT-guided self-help. These are therapies that when we think about binge eating, which we see more often that's the eating disorder we see more often in Black American populations, all of these have really shown that they have been beneficial to reduce binge eating. But most of this information has been achieved in predominantly white populations. So one of our first questions is this going to help? Right? That's one of the first questions I've seen researchers begin to ask over the last couple of years. So with our established treatments that we know help reduce binge eating, help reduce disordered eating, improve eating disorder pathology, do these established treatments, are we going to have to change the treatment? Are these going to work for our clients? And so researchers, this was another sample of about 600 individuals who participated in treatment trials for DSM-4 diagnosed binge eating disorder. And so these charts represent the different types of treatment. So this blue was behavioral weight loss, which is a treatment that people have used to reduce binge eating. We have cognitive behavioral therapy. This multimodal green treatment was a combination of CBT and some medication. And then we have the control group. And so what we see here with the Black participants in the study, in all these treatments, we see that over time, binge eating remission increased in the Black participants, and it was significantly more than it was in the white participants. And so what the investigators, what they took from this study was realizing that when we can engage Black participants in treatment, we see that some of the treatments that we already have are able to help reduce the binge eating, and it might be even more effective than it is in white populations. And so, but our issue is how can we get these individuals to treatment? What we're going to have to think a little differently, because what we know is the disparities in the access, and then when they're there, they don't stay. And so what can we do to think differently? But this research study showed us that, and we continue to need more research, but our current treatments for binge eating are helpful. And so we just have to find a way to get this information to this population. So I want to talk a little bit about another self-help treatment called appetite awareness training. And so this program, if you think about what we know in modern about intuitive eating, this program helps participants to honor and adhere to their biological signals of hunger and satiety. And so my team was able to conduct some research just to see about the feasibility of this treatment in a sample of Black women who reported binge eating. And so what we saw it was an 8-week study. And so it was, they compared to a waitlist control group. So what we noticed is that participants who were engaged in appetite awareness training, they had greater decreases in binge eating scores, and the retention was higher in the group, and participants really found it was a feasible and acceptable treatment. So just to give us some early information that this was not explicitly tested. This appetite awareness training wasn't explicitly tested with Black populations at first, but we see once they were exposed to this intervention, it really was, it was beneficial, and it gives us promise for what it might do in the future. We also have to think about, when we look at reducing disparities, the role of self-care resources. What we see in the literature is that access to self-care resources can often be one of the first stops for an individual who is managing a binge eating disorder, managing binge eating behavior. And so these are just an example of several resources. And if we're thinking how we can reduce the disparity, how can we make known, right? How can we use the internet and the media to make known how helpful some of these self-care resources might be, to get them in the hands of those who may not come to treatment, right? But they can still get help and assistance to manage their disordered eating behavior. We might have to think differently because everyone may not have the means or the access to treatment, but we have to make a way so people know that they can get the help that they need. So when we think about just a model, right? A model of intervention for Black Americans, we might need to just think about just a couple of different things, right? And think about how we can, at different levels, how we might be able to help. So on an individual level, if you are seeing a client in your office or you're working one-on-one, we see that it's important for education. Psychoeducation is incredibly an important intervention and should not be minimized, right? It seems sometimes we might skip over it, but just to provide education that this is indeed disordered eating and what someone can do to make things better, to validate their experience, I think would be a critical intervention for Black Americans, since there's not a lot of knowledge about eating disorders in this community. Also, when we think about awareness of the coping skill, using food as a coping skill, we must increase awareness and really begin to assess the role of coping and whether or not, individuals are coping or they're healing, right? And so we might, to push individuals towards healing, we might have to help them engage in some alternative coping skills and to really help them to begin to see things and find new ways to manage some of the challenge, to speak the things that are unspeakable and to manage some of these challenges. Finally, how are we going to provide support for these experiences of stress, racism, microaggressions, and trauma? Because these are the things that are affecting the eating behaviors in this population. And so our work is going to have to be to support. When we think about providers, we have to begin to increase the awareness that eating disorders may not develop as a response to that over-evaluation of shape or weight. There are other reasons. And so we're going to have to recognize that it's going to show up a little bit different. And so we're going to have to dig a little deeper. We're going to have to acknowledge the role of stereotyping and how that has hindered our ability to really assess disordered eating in populations that aren't white. And then helping identify training on culturally relevant definitions and norms of disordered eating. At the family level, thinking about the meaning of food in someone's family, in their community, and again, being able to talk about expectations of eating behaviors and how some of those expectations might have been helpful, might have been facilitative at a certain period, but now maybe need to be shifted to help our clients achieve their best version of and their quality of life. And then we think about, where are we providing on a system? Where do we provide our treatment for disordered eating? And we think about, how are we going to create new ways for, people who maybe aren't coming through those mainstream circuits to get treatment? And so I have seen an increase, in providing treatment that's provided in digital ways, digital health platforms, digital health programs. There is additional research on expanding treatment in primary care settings. For Black Americans, particularly, the primary care setting is probably one of the main places that they receive care. And so we just have to be able to work in alliance with the primary care physicians so that we are being able to really kind of give them the training so they feel confident about their ability to kind of assess disordered eating in a quick way, and able to help. And also being able to, when we think about what we've seen in the literature for Black Americans, that likelihood maybe to engage in treatment for weight, but more likely to do that than to engage in treatment for eating disorders. And so how can we meet our clients, meet our patients, meet potential research participants where they are? And so if they know more about engaging in weight loss, how can we maybe, with that desire, kind of meet them and begin to also provide some education about disordered eating, to really help with weight stabilization, to really help kind of prevent weight gain in a way that maybe makes sense, where clients might be interested and they might be showing up for treatment for some of these things that their doctors have told them, maybe you're at risk for type 2 diabetes, or you're at risk for other cardiovascular disease. And so they might be interested about talking about that, but that might be an opportunity for you as a clinician to also begin to kind of assess and see some of the eating behaviors and whether there might be some disordered eating there, and then to work as a team to begin to help in that setting. So when we think about treatment, our opportunities and challenges, we have very limited evidence-based treatment. Our interventions that have included a hardy sample of Black participants, we can count on maybe 3 or 4, 2, 3 interventions. And so we have to find a way to recruit and to reach this population so that we can understand how we're going to treat disordered eating and how we're going to improve our ability to reach them. We also, though, when we recognize that people aren't coming to treatment, we have to think, how can we reach them, right? And so just changes in the setting, changes in our recruitment strategy, and then thinking about what are some cultural factors that we can include in treatment. And maybe how can we leverage, we've seen more and more articles on the internet, more and more people who are celebrities talking about their experiences with disordered eating. And so being able to connect our community so that we can all help one another. In summary, what we see is that eating disorders do indeed affect Black Americans, and binge eating is the eating disorder, binge eating disorder, bulimia nervosa have the highest rates in this community, similar or higher prevalence of binge eating. We recognize the disparities in access and retention to treatment. And we see that it might look different. It may not be the over-evaluation of shape or weight. There might be other things, right? Trauma, stress, poverty, racism, a culture to stress that may contribute to development of an eating disorder in this population. And so because we have limited evidence-based interventions, we see, though, that there is hope and that we might be able to, we just got to find a way to get this information into the hands of our clients. So our future research just needs to examine the prevalence and the nature of eating disorders in other populations, because I know Black Americans aren't the only ones. There's so many BIPOC populations, Asian populations that have not had the research that we need, gender and men, we have to LGBTQ. We just need to expand our research so we can really understand. And this is a challenge to those of you who are watching as we really work to expand the literature and to bring what we know so we can help others. Okay, so that concludes my presentation. I wanted to open it up to questions.
Thank you, Dr. Good, once again for such a wonderful presentation. We will now open up for questions. We ask that you type your questions in the Q&A box. As a reminder, you will receive the evaluation after this webinar. This webinar's recording will be available via the NC Training Center at www.ncdus.org within two weeks from today's date. So I'll go ahead and address our first question. And that states, I am a nurse practitioner and a Black mother of a teenage Black son recently diagnosed with ARFID. Our journey to get a diagnosis and treatment has been challenging on so many levels. Can you speak to this eating disorder as well? Thank you.
LaShawn, I'm sorry, I didn't quite hear the eating disorder.
ARFID, ARFID, ARFID.
ARFID, okay. So I don't have a lot of experience with this, particularly with this eating disorder, but first of all, I would like to provide some resources that I have found to be helpful to kind of create, to be able to find some information. So one of the first places that I have found that I'm able to direct people to that has things in lay language that is helpful are some of the reports on the National Eating Disorder Association. They have written, just some good information for a lay audience. I also would direct to the resources for NSEED here. Again, information that hopefully is accessible. Well, what I imagine when I think about your question is I know there's nothing probably out there in the literature. And so you are on a journey that really has not yet been traveled, which makes it really hard when you are thinking about trying to find the help and the treatment for your clients, your son. And so sometimes what I think has been helpful is for people to reach out to clinicians, in the community, those who might be eating disorder specialists in your community, because they might be able to kind of give you some pointers or some ways to begin to kind of take this journey, especially when there's not a lot of research out there. And I know this is not an area where I have expertise. And so that's what those would be some of my first stops, is to reach out to the community and be able to kind of reach out and maybe find someone who might be an expert to help give those preliminary steps.
Thank you, Dr. Good. The next question asks, on the system level, are there ways that treatment centers can adjust or adapt to better engage and retain Black clients, whether that is programming or insurances or et cetera?
Sure. So I think one thing that might be helpful is, I don't know how many Black clients one might have, but be able to provide spaces where people who identify maybe as Black or BIPOC can come and be able to maybe meet together, right? To have a support network where they, maybe some racial affinity spaces where they can come and they can get just individuals. One thing I think that makes it hard sometimes is that when people engage in treatment, they're by themselves, right? And so they are going to be talking. They might be in a treatment group where they're the only one of color. They're the only Black person in the group. And it's hard enough sometimes just to say, I'm going to go get help. But then when you're in that space and you feeling culture shock, you're feeling like this is not a space where I feel comfortable. And so how can we then, knowing and anticipating that might be the experience, begin to kind of jump ahead of that a little bit? And so already have a platform where, we're inviting our clients who identify as a certain background to come and get the support. Maybe having like a mentored person who's just there to provide support, hiring clinicians, hiring a point person who might be there just to reach out, right? Just to kind of provide that extra touch, because when we have individuals who are kind of on the fringes, who may not feel comfortable being engaged in our treatments, we have to then think about how we can kind of create additional supports. And so we've seen that in other areas where we have tried to bring people of color into environments that they haven't typically been in. We have to have a lot of support so that when they start to have that feeling like, I don't know if this is for me, we have some information and we can reach out and kind of begin to kind of help say, yes, it is. And we're going to help you through it at every step. So they are surrounded and they feel supported.
Thank you again, Dr. Good. The next question asks, do we know why there's an elevated number of people in regards to the treatment dropouts? So the elevated rates of treatment dropouts.
So we have a couple reasons. One is that experience of being maybe the only one of color, that feeling, of being the only one of color in a particular treatment environment, and how challenging that is. And sometimes people aren't prepared psychologically for that experience. Also, sometimes there has been, you with providers, people have not always felt that they identified with their providers. I've seen that in the literature, and may not feel, and that's something that's very important, especially when you have an identity that has been marginalized in our country, is to be able to know that your provider gets it, right? And you feel like they get you. And so again, if you're not a person of color and you're entering into treatment, you want to know your provider gets you. And so we have to just think about, how can we extend that, us with race and ethnicity, how can we find a way to communicate to our clients, hey, we get you. So, because often, if we're going to be honest, most of our clients are going to be engaging with a clinician that is not their same race and ethnicity. And so we have to find a way to begin to create an environment where we can just kind of help our client connect. So in that way.
Thank you once again, Dr. Good. The next participant says, excellent talk, Dr. Good. Do you have suggestions for increasing participation of Black Americans in research as well? That's such an important first step in building the evidence base.
Yeah. I do have suggestions. And I think about these suggestions are what I find for what I found. So there's all levels. So one thing, when you think about participating in a research study, there has to be the trust. And I think that's the first thing. Is often there has been a history of mistrust. And so in many communities of color, there's just mistrust. Just like we see with the COVID-19 vaccine, we've had to kind of take the extra step to ensure to these communities that you can trust us. So that means having people that look like them at all levels of the research, from the team, the principal investigator, creating opportunities. So what I find myself doing in my research lab is creating opportunities for undergraduates, people at all levels of education, to buy in and see themselves in the research process, because they see themselves and then they go and they can vouch to a member of their community, their network, hey, it's okay, we need you. And so often snowball sampling is one of the main ways that I have found that it's how I help people participate in my studies and other studies, is being able to say, hey, I vouch for this, and please come on and try this. Because people just have to be able to feel comfortable, and they have to be able to feel that there is some trust there. And so I think as the research, if you are the principal investigator, there's some questions that we have to begin to ask. What are we asking people to participate? Who is at the door when we are asking them to participate? When they participate, who is going to be on the team? And so who is going to be in the room? And we're asking often people to do things that are very, very uncomfortable. And so it's going to take, it's not a quick answer, but it's a way, how can we support, our participants, and letting them know. And so it takes the extra mile, going to some of these community-based settings, conducting the research in the actual community. I know in my clinical trial I presented, I did that in the community. So they didn't have to come anywhere that wasn't familiar to them. And even though I was a member, I was the same racial and ethnic background, I still had to, they still didn't know me personally. So I had to trust me. So I had to be in a space that is more comfortable for them.
Thank you once again, Dr. Good. And we have one last question. If there are any other questions that are written within the Q&A box for unanswered questions, we'll have Dr. Good send you a response to all attendees within 1 week from today's webinar. The last question asks, do you have any suggestions for how I can both meet clients where they're at, if they're coming in believing they have a weight versus eating problem, while staying true to my health at every size beliefs and not playing into anti-fat biases?
Oh, that's a good question. So I think the challenge would be to find the alignment with what can you all align with and how we can help. And so what I found sometimes is my participants, they're interested when they're coming to my studies to reduce binge eating, they're interested in weight loss and they have their reasons why they're interested in that. And so my interest is helping them improve their eating behaviors. And so it's recognizing what can I do to focus on the areas of shared mutual interest. And so, and then the things that we don't, may not see eye to eye on, or they're in a different place. Let's just start with where we can agree at this moment and then continue to work together. One, you're going to build your rapport, you're going to build your relationship, and then you're going to build your trust. And then you might have a greater opportunity to bring in some of the other things that you all might not see eye to eye on. And then not making clients choose right at the beginning, but being glad that they're here, they're ready to engage. And so let's just start the journey and begin to, and I always think your foundation is your relationship and being able to adhere to your biological signals of hunger and satiety. So let's work on building your foundation and continue to kind of help you grow. You're not saying you would be dishonest, but being able to say, well, let's start here. And if you're willing to start this journey, I'm willing to start with you.
Thank you once again, Dr. Good. This webinar was definitely a wealth of information. We are very grateful that all of you were able to attend today's webinar. As a reminder, the recording will be available 2 weeks from today. And if you would like to receive any other additional information, you will receive Dr. Good's email along with the evaluation after this webinar has ended. Thank you once again for joining today. And once again, Dr. Good, thank you so much for your time.
Thank you.